where do we stand? Pediatric cataract, where do we stand now? So we start with the basic evaluation by Dr. Satish Thomas. I have with me Dr. Meena CK to co-chair. Let us go on to the talk. Yes.
So I don't know whether this topic will be required, because I think all of you will be well versed with it. The seniors who are already handling so much of pediatric cataract will have to forgive me, because it's a very basic talk. So what's different about pediatric cataract as compared to adult cataract? Almost everything's different, apart from the fact that there are lenticular opacities in both. So the etiology is different in pediatric cataract as compared to adult cataract. So that will influence the way we work up our patients preoperatively. The anatomy of the eye is different, and that would influence our surgery, the intraop considerations. The way the eye reacts to trauma, to surgery, is very different. So it will have post-op implications. Amblyopia becomes very important in the visual rehabilitation, and it's a growing eye that we are dealing with, therefore importance in the IOL power calculation, size of the IOL, and in the complications. So about etiology, the majority of the cases are idiopathic or hereditary, but we have to rule out some of those other causes, whether they are ocular anomalies or systemic associations, though those are much rarer, but they have to be looked out for. So the ocular disorders that can be associated with pediatric cataract could be aniridia, microphthalmia, PHPV, and the anterior segment dysgenesis syndromes. Systemic conditions where you can get a pediatric cataract associated: Down syndrome, Loewe syndrome, Alport syndrome, the torch infections, hypoglycemia, galactosemia, hypoparathyroidism, and other metabolic disorders. And then we can rarely have steroid-induced cataracts or traumatic cataracts among the pediatric. So we would look for them when we suspect them and investigate accordingly, tailor-made. Coming to the morphology, it's mostly lamellar cataract that we have in the developmental cataracts. We can have the zonular cataract with the spokes or the coronary cataract, all the various manifestations, but mostly it's one zone that's involved. The timing of the surgery: not all lenticular opacities in a child have to be operated. Pediatric cataract has to be taken care of when we know that it is going to interfere with the visual development in the child. And so whether it's going to cause amblyopia and visual development is the most important consideration. A central opacity that would obscure vision, stimulus, and cause stimulus deprivation has to be taken out. Obviously, a unilateral cataract is more amblyogenic and therefore should be operated earlier than a bilateral cataract. So quickly coming to the surgical challenges in a pediatric cataract, the intraoperative factors that make a pediatric cataract surgery a challenge is that we are dealing with a smaller eye, so less space in which to operate. The scleral rigidity is low, and how this would make the surgery difficult is that there would be more frequent AC shallowing, and therefore the capsular excess can keep running out, and we need to suture such a wound because the scleral rigidity is low. The capsule in a child is more elastic as compared to an adult, therefore you need more force to fracture it, and therefore it can tend to run out more than an older capsule. The nucleus is soft. That is one thing that makes a cataract surgery easier in a child, and so we don't need phaco energy most often. And a posterior capsule would need management always, and that's how it differs from an adult cataract, and the need for an anterior vitrectomy also. General anesthesia is always required in a child IOL power calculation is most often to be done on table, so therefore we would have to bring all our machines to calculate the IOL power into the theater. Wound construction, a scleral tunnel for a rigid IOL because you need a big wound. You can probably do a limbal wound for a foldable, but either ways, they always have to be sutured. And high molecular weight viscoelastics are helpful. So this is how an anterior capsulorhexis is done. We begin by fracturing the capsule. And because the capsule is elastic, we need more force. And it tends to run out. Therefore, the force is applied towards the center. So it would be a centripetal force. Try and keep it smaller, and invariably it would end up bigger than what you aimed for. A rough guide would be like in a lamellar cataract like this. Try and keep the size to the margin of the opacity. So the force that you apply is always towards the center. Keep grasping and re-grasping closer to the tearing edge, and that's how you can get a continuous curvilinear capsulorhexis. And that's very important in a pediatric cataract because the anterior capsule integrity is very crucial for long-term centration of the IOL. It reduces the chances of optic capture, tilting, and extrusion into the anterior chamber. Before continuous curvilinear capsulorhexis came, this would be one of the main reasons why a pediatric cataract would have a poor outcome. Lens removal, I think I can skip this because it only requires phacoaspiration. And after that, primary posterior capsulorhexis becomes very important in a pediatric cataract. So we can do it in the same way the anterior capsulorhexis is being done. First, the tear is made with the cystitome, and then we go round and round with the Utrata's forceps. Again, pull it in a centripetal fashion. Try and keep it smaller than your anterior rhexis, but central. And always do an anterior vitrectomy, because if you don't do an anterior vitrectomy, then the after cataract that forms would grow over the anterior hyaloid face. So the vitreous doesn't prolapse like in an adult because it's in a gel form, and that's a good thing. So even if there's no vitreous prolapse, you still go into the vitreous and then remove a bit of the anterior vitreous so that there's no scaffold for the growth of the after cataract. So visual axis obscuration is the most common complication in a pediatric cataract if you do not take care of the posterior capsule. So these are some of the ways in which a pediatric cataract can present later. So the most important thing in a pediatric cataract would be those circles that you see. The anterior capsule, a good circle in the anterior capsule, a well-centered IOL, and a good posterior capsulorhexis. This would ensure that your visual axis remains clear long-term post-operatively. So even when the capsule opacifies, you have the central clear area, ensuring that your visual axis remains clear. You can also do an optic capture to try and ensure that the visual axis remains clear. But if you've done a good anterior vitrectomy, then an optic capture is not necessary. So these are just photographs to show that opacification is invariable and quick immediately post-op, but if you've taken care of it in your primary surgery well, the visual axis continues to remain clear. An IOL insertion into a bag that's already open posteriorly needs care, can be a little tricky. Just make sure that your leading haptic goes into the bag fornix, and then you can direct the haptics into the bag carefully. You can also implant the IOL and then go behind the optic and do a rhexis after you've done the IOL insertion, so that makes it a a little easier. So in the bag, implantation of the IOL is strongly recommended. You could either use acrylic or PMMA, but if you're implanting it in the sulcus, then obviously not a single piece IOL. You could go for a heparin surface modified IOL if required. So thank you for your patience.
On time. Thank you, Dr. Satish. And that was covering the basic evaluation and surgical challenges. Yes. Now I call upon Dr. Meena CK for challenges in microphthalmia in pediatric cataract. Dr. Meena is the consultant pediatric ophthalmologist in Little Flower Hospital, Angamali.
Good afternoon, everyone. Actually, this talk was by Professor Cocker, and obviously all of you know that I can't be a replacement, but I'm just sharing a few of my experiences with microphthalmos. So coming to microphthalmia, microphthalmia radiologically has been described as an eye with an axial length of 2 standard deviation below the age-adjusted mean. So you can have usually microphthalmia isolated is rarely seen, but definitely occasionally you see isolated microphthalmia where there will be no other associated features, but syndromic is more common. You can have other systemic syndromes along with it. Then when considering the eye itself, you can have simple microphthalmia where all the parameters will be reduced, all the dimensions will be reduced of the eye, which will be equally reduced, but you can have complex microphthalmia where you can have anterior segment problems, posterior segment problems. The common one of which is colobomas, PHPVs. So these are the complex type of microphthalmia. I'll go through, it's mainly a video based presentation. I'll go through few of the videos of my microphthalmia patients. And here you can see the corneal diameter is almost around 8 millimeters, and this is actually more or less a simple microphthalmia. You have a pointer. Simple microphthalmia. You can see a small coloboma there, but it's an incomplete coloboma and it's not creating any problem for your surgeries. So each step is little different in microphthalmia, because when you feel that there is some problem to your rexus, like you can't pull it properly, then you shouldn't try to do it, because you can have a microphakia associated with it. So then you can convert it slightly with a micro scissors and then continue with this. So here you can see the nucleus was very hard. It was just like an adult nucleus. So I had to go for a phacoemulsification. I usually don't do phacoemulsification, but in this case I had to use the phaco probe to remove the nucleus. It was that hard. And posterior capsulotomy was easy in this case. It was just like any lamellar cataract. So it's like each case is different, but cases like these of microphthalmia, they are usually easy to manage, because it behaves usually like the normal lamellar cataract, and even you may be able to put an IOL later. This was in the early months of life, so we didn't think of putting an IOL. So here you can see a little bit of visco going into the anterior vitreous, which is a proof that the anterior vitreous cavity has been opened. That is one problem with pediatric cataract. Sometimes you feel that you have opened the anterior vitreous cavity, but it might be intact. So make sure you open it. It's just like a posterior capsule. So you have to open the anterior vitreous cavity, which is a must, because otherwise it will opacify very fast. Now coming to the next case, like this was a more or less a severe microcornea, and you can see only that center part is open. Pupil, only that much of pupil is there, and you can see a central plaque cataract. So I couldn't do anything but to use a pupil dilating devices, and again you have a microphakia here. It's only 5 millimeter cataract. So rexus, again it's difficult, like you will have to convert the rexus with vitreous scissors and do it carefully so that it doesn't extend to the zonules. And here excess is getting completed, and you can see there isn't much of, sorry for the video quality, much of cortical matter there. It's just that plaque you can see there. And when you lift up the plaque, you can see the PHPV behind that. And it's just like a pancake sitting on the posterior capsule. And I'm trying to lift it up and remove, but it's attached so tightly to the posterior pole, it can be dangerous. So you have to just cut it, otherwise you will give undue pressure on the vitreous base. So I'm cutting it and just removing it, not much bleeding from the PHPV. So that plaque was quite hard, and I'm removing it through the side port and followed by a vitrectomy. Here there's no question of PPC, the PC is already opened up, so just doing a vitrectomy after that. Now coming to this case, this is not much of a microphthalmos, but since the stereopsis is not good in this video, this is almost a flat anterior chamber. Like, it's so difficult to introduce an instrument into this. And the corneal diameter is something like 9 millimeter. I'm just trying to just debulk it with the help of a needle. So I just opened it with the help of a needle, and this is a cortical aspirator. I'm just aspirating so that I can get some space in the anterior chamber. So the cortex is aspirated, and once I start putting instruments into the anterior chamber, you can see the iris coming into the wound. That is the biggest problem you have when you do pediatric care. You shouldn't have that problem, but when you have a small pupil and when you have a crowded anterior chamber, this is a big problem. And I'm just aspirating whatever cortex is there. But now you can see that it is a big plaque on the posterior capsule. I usually shift my positions on the table. That's why you are seeing the images nasally and temporally occasionally for convenience of surgery. And here you can see that I had to cut it with vitreous scissors. It was that hard. It was not yielding to vitreous vitrectomy also. So I had to make a clear visual axis. So it's getting cut with the help of a vitreous scissors and micro forceps. The problem is you have to maintain the anterior chamber, and here the iris repositor helps me to keep the iris at bay so that the iris won't come into the wound. I'm just trying to separate the iris from the vitrectomy probe. Otherwise, once you disturb the iris, it's very difficult. It will keep on coming into the instruments. So here a clear visual axis is there, but you can see it's such a thick posterior capsular opacity, and you can see the drawn ciliary processes also in the periphery. Now coming to this case, this is also a mild microphthalmos along with the PHPV, but PHPV is quite visible here. This is after cortical aspiration, and here the vessel is quite huge. The PHPV vessel is quite huge. So in such cases, you should suspect bleeding from the stalk coming from the optic nerve head. So here the posterior capsule is being cut, and you can see the bleed coming, and an endocautery is being used for that. And usually it doesn't bleed that badly. So if you use an endocautery and just cut the visual axis, cut the opacity in the visual axis, and here you can see the blood vessels falling back, and the vitrectomy is being done, and you can see the blood vessels in the stalk falling back, and no more bleeding after that. And it's also associated with a coloboma. So this is the first case actually. This child, whenever you manipulate the iris of this children, the next day it will be okay. Like even for 2 weeks, the first follow-up also, it might be okay, but they might come back with occlusio pupillae. That is one problem. There can be severe reaction in these children and this child, and usually we tell them, like, if you have any problem, any discoloration of the cornea, or you feel anything different in the child, immediately bring the child. This child they brought after 2 weeks of the symptoms, and there was significant corneal edema, and you can see there was no pupil at all. It was an occlusio pupillae with a membrane, and it was very difficult removing it because there was no space in the anterior chamber. And I tried doing, removed it with a vitrector, and a pupillary visual axis was made. And though a PI was done earlier, the PI got occluded and again a PI had to be done. We could make a clear visual axis here, but still whenever you manipulate the iris, you can have problems. So you have to be very careful when you use hooks. Maybe the surgical procedure you can get away with, but the post-operative problems which might come later is an issue in these children. Thank you for your patience.
I was looking for you. I thought you are still in the other. So now we go on to, thank you, Dr. Meena. That was a wonderful video presentation of microphthalmia. So now another challenge is visual rehabilitation and follow-up after surgery. So moving on to Dr. Kalpana. Dr. Kalpana Narendran is the head of the department of the Pediatric Ophthalmology Department in Aravind Eye Hospital, Madurai. Sorry. Coimbatore.
Okay.
Thank you. Over to you.
Thank you for the opportunity. And it's so nice to see some audience. In the other hall, only 5 of us and only 5 of us. But we
I'm
spoke
sorry for
seriously.
that.
No, I'm saying, no, this is nice, man.
Getting all the best faculty and having only the speakers actually is really sad.
No, it's nice.
Thank you for being here.
So my topic will be visual rehabilitation post pediatric cataract surgery. We all know that, when we see a pediatric cataract patient, what we tell the parent is, just don't think that by doing the surgery it is over. By doing the surgery, only 50% is over. The 50% is a follow-up and rehabilitation. Because not like in adults, you just remove the cataracts and they'll be fine. So we should always keep that in mind to counsel the parents regarding the rehabilitation and the follow-up. And we all know that the very important thing in the child is to get a good functional outcome. And following which you have to think about the rehabilitation to give, because children have longer living years. So we have to keep that in mind and don't do anything aggressively or, don't make adventures in children. Where it's always better to be conservative. Only if something is time tested, proven, and you are good at it, attempt to do it. Because don't make blunders and make these children blind for their lifetime. And there is always this dilemma that when there is a cataract like this, bilateral mature, what you would do, and you should always keep in mind there is not one problem. One is it affects the visual pathway maturation. Second, stimulus deprivation amblyopia, and retards emmetropization. So all these, and also it affects the IQ and the development of the child. So it is definitely a complex problem. So first thing is to clear the opacity. You have to make the visual axis, good and clean and make the child see. So the intervention, again, 4 to 6 weeks of age based on the unilaterality or bilateral. Unilateral, younger age, usually 2 weeks. The child is healthy, no other complications, you can operate. In bilateral cataracts, 6 weeks of age. This aphakic glaucoma, definitely there is an option. But I think as practicing pediatric ophthalmology, we would say that incidence has come down a lot. And even there is an IOP rise, we can always treat it with good medications we have now. And the post-operative rehabilitation, one is give a optimal visual stimulus. One is by removing the opacity. Second, by giving them aphakic glasses or contact lenses if the patient is compliant. In our setup, contact lens is not very well accepted unless the parents are very educated. And then intraocular lens is an option based on the case selection. Then followed by effective amblyopia therapy, because most of the children are going to present to you at a later stage. So amblyopia therapy should also be part of the rehabilitation program. And what difference is this IOL going to make these children? You are seeing here the thick aphakic glasses sometimes cosmetically may not be acceptable. The images will be big. Child will not have good peripheral vision. Will have to move his head for the field of vision. So this will give you a good quality of vision. For the patient, cost, I won't really talk about it here. But then compliance problem is not there. And but younger children, if you implant, definitely there is a problem because you have to think of resurgeries and good quality of life for child and the parents. But again, the downside is there are certain advantages that the child can regain the binocular single vision and maximizes visual outcome, cosmetically good and all that. But the disadvantages is visual axis opacification, myopic shift.
keep in mind that you're putting a lens in a growing eye. So always keep the myopic shift in mind. So that also can be a big problem. Sometimes you later on, if there's a gross myopic shift, you may have to go in for an IOL exchange, and it can also give some anisometropia along with your added stimulus deprivation amblyopia. So we should keep all that in mind. And the minimum age for IOL implantation, I already told you this, bilateral cataract, usually about 8-9 months of age, and unilateral, earliest is 3 weeks if the corneal diameter is more than 10 millimeter, no other associated pathology, and if the child is going to come for regular follow-up. If you put a lens and the child is not going to follow up, you're making more damage. If that child is a poor socioeconomic status, not going to come follow up, leave him aphakic. It's always better to leave him aphakic rather than putting a lens and creating more problem. And this is just a small surgery of how, pediatric cataract surgery. It's very simple. Like she said, if you treat them and do it the right way, usually the eyes are very quiet, and the only thing is the capsules, it's not a miniature adult eye. That we should keep in mind, because the capsule is much elastic. So if you're wanting to do a 5.5 mm, you have to be very, the way you do it is a little different. And thorough cortical cleanup is very important. If you leave behind some cortex, there is a possibility that the PC fibrosis can be much faster. So that's very important to do a thorough cortical cleanup. And a primary posterior capsulotomy, which we normally don't do in adults. So that is very important to keep the visual axis clear, especially children below the age of 8-9 years. Just doing a good cataract surgery does not suffice. You should do a good primary posterior capsulotomy with anterior vitrectomy. That is very important. And it's better to suture the wound. Once in children, because they'll rub their eyes, and especially when you do a vitrectomy, always close the wound with a 10-0 vicryl suture, which usually you don't have to remove, but sometimes if it causes irritation, then some debris the child develops like infection, then you have to remove it. Then the primary posterior capsulotomy is indicated, like I said, above the age of 8-9 years. You just do the rexus, don't do vitrectomy, or you can just leave the capsule intact. And children with delayed milestones who may not cooperate later for YAG capsulotomy, they will be ideal candidates to do a PPC even if they are older children. And also if there is a plaque in the posterior capsule, then it is better. So this is a slide showing how the visual axis, you can see the anterior axis margin as well as the posterior axis margin. And also you can have patients like this who present to you later on, with this kind of a fibrosed, this was a traumatic cataract, I think, so you can see the fibrosis. So sometimes if you leave the antivitreous phase, there will be lens epithelial cell migration, then the fibrosis will form on the anterior vitreous phase. So secondary operations like membranectomy have to be kept in mind. And inflammation, usually now, we used to keep these children for 2 days post-operatively, but now eyes are quiet. Older children, we discharge them the next day like adults. But we keep them in the hospital because it's under general anesthesia. We do not do cataracts at daycare, and most of our patients are traveling from different towns, so we keep them for a day. But younger children, less than 2 or 3 years old, and we keep them for 2 days in the hospital. We were discharging them, but then we burnt our fingers. We saw some of them coming after 2 weeks, like Dr. Meena showed, like with membrane and the Sinike and the resurgery after 2 weeks. So we try to keep them, because sometimes the child does not complain, they don't put the drops in the right time. So that is what will cause problems. And of course you treat them with steroid antibiotics, ointments in small children. We give atropine ointment for aphakics and homide drops for pseudophakic children. And this is for 4 weeks in tapered dosage. And the successful IOL surgery again depends on the selection of cases. I said up to the surgeon, the right IOL power, and keep the myopic shift in mind, choose the right formula, careful post-operative monitoring, and always look for the PC opacification. Most importantly, educate the parents regarding the follow-up and the refraction and the glasses. So the glasses usually will be given at the end of 4 weeks. So, and the gap between 2 eyes, we operate one eye, the other eye will be operated after 2 weeks. That is the norm we always follow, or after 10 days. And the follow-up will be based on the age of the child. Usually the younger ones, less than 1 year, we see them once in 3 months. Then after 2 or 3 years, we see them once in 6 months. After 5 years, we see them almost after 6 months till they are about 10 years of age.
just to see if there is any refractive change, and check the IOP, and fundus evaluation is very important in these children, and also check for binocularity and intraocular pressure. It's very, very important in these children. So like I already mentioned about the follow-up, and if there's an underlying amblyopia, the treatment is usually with patching. Now vision therapy also can be tried. So to conclude, visual rehabilitation in pediatric cataract is separate thing. So you have to convince the parents and counsel them accordingly. Always try to achieve optimal visual outcome, adapt new visual abilities. That is good for the children to have a good quality life. It's a team effort and needs more than anything the patient cooperation. Thank you very much.
Thank you, madam, for that wonderful talk. The next speaker is Dr. LEILA Mohan. All of us know madam. Madam is the head of the department of Comtrust Eye Hospital, Calicut. She'll be speaking on management of unilateral congenital cataract.
Thank you, Dr. Meena. We are talking about the challenges of pediatric cataract. Most of it has been already dealt with. What are the special challenges in unilateral cataract? So it's mainly due to the late presentation because they already have a seeing eye, and the deprivation amblyopia which follows, and the associations in unilateral cataracts, as Dr. Satish has already pointed out, localized ocular dysgenesis, PHPV, ocular infections can produce unilateral cataract also, like rubella and cytomegalovirus. We have been seeing cytomegalovirus more than rubella nowadays after the immunization schedule. Often they are nuclear with posterior capsular plaques. PHPV is very common, varying in prevalence in various studies. Andrea Mullner has shown almost 100% of her cases being unilateral. And Dr. Sudarshan Kokar has shown that it is about 28 to 30% in their study among the unilateral cataracts. In our practice also we have seen, Dr. Meena was showing many of her cases with microphthalmia having PHPV, including the posterior capsular plaques. We have about more than 60% of the cases being unilateral, of the unilateral cataracts having PHPV. And amblyopia management and follow-up is critical, which is frustrating for the patient, the child, the parent, and the surgeon. I'll see you. So when should we operate in a partial unilateral cataract? When there's a partial unilateral cataract, there is no nystagmus. We want to know when should we operate. In the mild forms of dot opacities, which are very common, sutural cataracts, when they are referred to our OPD, we don't need to tackle them unless they are visually significant. So as already pointed out in the basic evaluation, the morphology, because vision cannot be tested in a newborn. In an older child, we can test telar acuity, but in the newborn, we cannot see whether he can see or not because of the cataract. So often the morphology of the cataract is taken into consideration. A centrally located cataract of more than 3 millimeter size, posteriorly located confluent cataract which obstructs vision of the macula, strabismus due to the cataract. All these are indications for surgery in a partial cataract. Of course, in a dense unilateral cataract, as already said, it has to be operated immediately at least by 6 weeks. 4 to 6 weeks is the ideal time for a good visual outcome. If you put it off, then visual rehabilitation becomes more difficult because of the amblyopia. Work has shown that the visual outcome to be as good as in a bilateral cataract if operated by this time and amblyopia treatment is instituted. In older children, surgery should be done as soon as you see them, when there is total cataract to prevent further amblyopia deterioration. And screening is very important. As you see, this Bruckner's red reflex should be seen in the clinic of a pediatric department to rule out any new unilateral cataract. So whether we should implant IOL before 6 months is a great debate. Main challenge in unilateral cases being optical correction and amblyopia management, because the other eye is seeing. And outcome of IOL implantation before 6 months has been studied extensively. The infant aphakia treatment study group who did a long-term follow-up of 14 children, they've already done, almost going to be 15 years now. And these infants below 270 days of contact lens group and primary IOL implantation, 54 in each, 57 children in each, have been, after a long-term visual outcome in these both category have been the same, and but because the early IOL cases needed more secondary procedures, that is due to the visual axis opacification due to inflammation, and membranectomy had to be done in these cases more often. Second procedures had been more common. So they advise against IOL implantation below 6 months of age. And children in contact lens group had been given at least 9 contact lenses during a period of follow-up of 1 year in the US when they did this IATS study, which is not very feasible in our situation. And in developing countries like India, the contact lens feasibility is difficult, handling is difficult by the parent, and compliance is much less. So large periods of aphakia without any correction produces a very dense, irreversible amblyopia. So Dr. K. Kunaya from LV Prasad and others, many others, Dr. Jaspreet from Chandigarh, many studies show that IOL implantation can be done in selective cases of the newborn, the under 6 months. If the axial length is more than 17.5 millimeter, corneal diameter is more than 10 millimeter, with no anterior segment dysgenesis, IOL implantation is better because to manage them with the, even after surgery, because you can undercorrect by about 25 to 30% in these children, because the eye grows within first 6 months, it grows very fast. Even after implanting an IOL, we have seen about plus 15 diopters remaining. So then you have to closely follow them up and reduce the power. Optical correction is very important. So implantation, of course, above 6 months, if they meet the criteria of the corneal diameter and axial length, can be done in unilateral cases, should be done, because it is easier to manage. The amblyopia management is easier, and optical correction and patching is the most important, and visual axis opacification should be followed up. And so in these cases, because posterior segment pathologies, like Dr. Meena has already said, coloboma, detachment, all these things can be there. B-scan is a must, and severity of PHPV can be seen if whether it is a dense PHPV. Posterior segment should be ruled out with a B-scan. So pre-existing posterior capsular dehiscence can be seen with an anterior segment OCT, which is not very easily available. The handheld anterior segment OCT machine is not very easily available, but if it is incorporated in the microscope, we can see posterior polar cataract, PHPV, posterior lenticonus and lentiglobus showing the dehiscence, when we can be prepared for a 3-piece lens instead of a single-piece lens in the bag. So PHPV being the commonest uniocular cataract, you can see the thick plaque, very commonly seen. Dr. Meena has already shown in the a faint vascular remnant is always seen in the Clockett's canal, and plaque peeling should be done for the smaller plaques, but sometimes it has to be cut with microvana scissors, or as you see here, it has to be with a vitrector instead of a PPC. It can be, you cannot pull with the primary rexus. And extensive capsulectomy and anterior limbal, 2-port limbal vitrectomy can be done in many of these cases. Most of these cases, IOL implantation is possible. In vascular PHPV, as Dr. Meena has already shown, endocautery should be done to cauterize the vascular thick fibrous tissue, and then do a vitrectomy or even cut with microvanas, and then implant an IOL if the microcornea is not very severe, or better to leave alone. Majority of these cases are anterior forms. Posterior forms should be dealt with. If it is the Doppler B-scan shows vascularity, then it is better to be dealt with by the posterior segment surgeon. And sporadic posterior polar cataracts are often unilateral, and all the strategies like low aspiration vacuum, inside out aspiration as we do in a posterior polar should be observed. It has been seen in 7% of the unilateral cataracts, as Vasudha has shown, and the pre-existing defect may be there in 26%, and B-scan may show, so you have to be prepared for a pre-existing dehiscence, and you can still do a primary capsulorhexis around the posterior capsular opacity, and then always better to do a 3-piece IOL with the posterior optic capture where the IOL will be more stable. That is the capturing of the lens. So these are posterior lenticonus is another cause for unilateral cases. Bilateral often goes with syndromic cases, and OCT can show the integrity of the posterior capsule. Dr. Meena has already shown a video of rubella cataracts are very thick and sometimes calcific capsule, anterior and posterior. You need to put expand the eye pupil. They are quite often microphthalmic also, and all these predispose them for having glaucoma and inflammation and glaucoma, so they should be very closely followed up. This young 8-year-old boy presented with defective vision, and after a blunt injury, and we saw that there is a posterior capsular dehiscence. ASOCT also showed this. You can see the posterior capsular dehiscence here. And we were prepared for the PC dehiscence, and often these if they come later, there is a fibrotic posterior capsular dehiscence, so they don't give way. You can manage them with the strategies to use viscoelastic soften, low parameters like low fluid vacuum, and then often we can put implant an IOL. 3-piece IOL is ideal to be implanted either in the sulcus or in the bag, and then capture it posteriorly. So all traumatic cataracts which are open globe injuries, we have to follow them up, whether they have a large astigmatism, do biometry again and again. They show large astigmatism when there is a suture. And then you have to do surgical correction. After either the suture is removed, and then do a biometry again, and then do IOL implantation. A secondary IOL can be implanted. So I'll go ahead to the... So strabismus is very common. They may present with strabismus even before surgery in unilateral cataracts, and so refractive correction should be done as early as possible. If possible, if the air is absorbed in the anterior chamber, it can be done from day 2 or 3. You may start giving glasses, and patching too. Younger children may have large residual hypermetropia, as I said. It may look just like an FAK correction in the newborn. And they need to be followed up. Maybe after another month you may have to change. So up to about 2 years you give a monofocal, after that you give bifocal, but patching is the most important. So children in IATS were followed up for 10 years, and they found about 88% of them developed strabismus, and only 50% of them had surgical correction for strabismus after 10 years. So once amblyopia improves, you can do surgical correction. And early surgery by 6 weeks, of course, and patching, effective patching has shown a good contrast sensitivity also to develop. And when surgery is done later, this may not be the same. And follow-up, as Dr. Kalpana has already shown, what all things you have to look for. Glaucoma, often they are small eyes. So all the problems of a microphthalmic eye may be there, and follow-up is important. Large myopic shift should alert you to do an EUA. Look for IOP cupping, whether IOP cupping has increased. Often these children have a very high pachymetry. When the CCT is very high, you are not sure whether the IOP is very high. So you have to look under. They have they have myotic pupils also, so it's very difficult to see the fundus. So you have to look for the disc cupping, whether it is increasing. Under GA, always better in these children, young children. So a myopic shift, which is faster than expected, also needs immediate UA. And membranectomy when there is a visual axis opacification. Secondary IOLs can be done earlier in these cases. You don't have to wait till 3-4 years as you would do when it is a bilateral cataract. So it is better to do a early secondary IOL, and always better to capture it posteriorly. This you can see the fibrotic of PPC, PC opening, and 3-piece IOL has been implanted. And as all have pointed out, surgery is only the beginning. The rest of the follow-up is more important. Unless you have a good follow-up, it's of no use, especially in a unilateral cataract. I think when I did my post-graduation, there were a lot of roundtable discussions saying unilateral cataracts you will not touch because you are not going to gain anything by doing a cataract, because unless you are very aggressive with cataracts, with the amblyopia management, you will not gain anything by doing a unilateral cataract. But now the surgical techniques have improved, everything has given us an opportunity to give surgical outcomes better, but amblyopia management is important. This is Dr. Edward Wilson. Even anywhere in the world, in US also, they have the problem of lost patients after surgery. So aggressive patching chair time is very, very important. He stresses upon this. I had the opportunity to be with him. So we have in Malabar what I would call Gulf syndrome. After getting surgery, maybe after 1 or 2 months, they ask us, let me go and join my husband and come back later. And they come with a thick membrane and maybe PL or very dense amblyopia, which is very difficult to treat after 2-3 years. And this is so early surgery. And it is always better to do an IOL if possible, because once left phakic, it is as good. Phakic I can see maybe 1 or 2 meters. So unless they wear their phakic correction or contact lens, there is no point doing making a cataract to aphakia and leaving them. So post-operative management is very challenging, and counseling and follow-up is crucial. And you should look for pre-existing dehiscence and do surgical management accordingly. Thank you so much for the patient hearing.
Thank you, madam, for that informative talk. The next speaker is Dr. Dwideep Chandran. He'll be talking about anesthesia challenges in pediatric patients.
Dr. Dwideep is our pediatric anesthetist also in our hospital, Contrast Eye Hospital. Over to Dr. Dwideep Chandran for his...
Good afternoon. Myself is Dr. Dwideep Chandran. So we look into the pediatric anesthesia management thing. Yeah. So initially we'll see what are the anatomical and physiological difference between a pediatric patient and an adult patient. So as we have already discussed, just like in the cataract, the babies are not miniature forms of adults. So there are a lot of anatomical and physiological difference between the pediatric and adult population. The most important difference being their cardiac output is heart rate dependent. Therefore, the decrease in preload and increase in systemic vascular resistance and decrease in heart rates are poorly tolerated. And the goal of treating low cardiac output is to increase the oxygen delivery to the tissues. Our volatile anesthetic agents, the minimum alveolar concentration of these agents in giving effective anesthesia varies with age, but all decreases the BP. Now coming to the respiratory system, the diaphragm and intercostal muscles do not achieve type 1 adult muscle fibers until the age of 2. That means up to 2 years, the kids have an immature muscular system, and most of them are obligate nasal breathers. And then, as we all know, the narrowest portion is a cricoid cartilage. Also, the post-GA apnea is very common because the postnatal adaptation will not occur until 44 years of post-conceptional age. So, this post-GA apnea is common in premature and or anemic patients. Alveolar formation continue to occur until 18 months of age. Coming to the renal and hepatic changes, the complete maturation occurs by around 2 years of age. And the general physiology, they have the minimal ability to shiver for the first 3 months. So we need to heat the whole body, including the head, we need to cover the baby completely before giving anesthesia and doing the surgery. Now, as we all know, why this pre-op evaluation is mandatory in these kids. We know that all these diagnostic issues can occur with the children, like many of the underlying diagnoses and syndromic babies present with the cataract, strabismus, and glaucoma. They have this particular set of anesthetic challenges like difficult airway, difficult mass ventilation. Many of them have cardiac lesions, and they do have cervical instability. Like the Marfan syndrome and all are having a lot of cardiac lesions. They can present with the seizures in the postoperative period, and neonates as such have issues with the glucose control, temperature management, postoperative apnea, and bronchopulmonary dysplasias. Now, what are the ASA recommended? American Society of Anesthesiology recommended minimum mandatory workups. So these workups we do for our kids, and most of these kids are post-sepsis survival kids. So it's prudent to see the CRP level along with the CBC when you see these patients, especially when they have some signs of infection like a fever or tachypnea or tachycardia. And we do echo when we suspect a syndromic association which can present us with a cardiac lesion. Now I wanted to clarify some of the myths about the increase in intraocular pressure and anesthesia. So most of the time the young ophthalmologists think that the anesthesiologist is making your surgery difficult with their drugs and their methods to increase intraocular pressure. So we'll see what are the things about the increase in IOP. So most of our induction agents lower IOP except ketamine. But with the ketamine, the increase in IOP occurs at 5 mg per kg level. So usual doses of sedation like 2 mg per kg or 1 mg per kg of ketamine will not increase IOP, so that your surgical difficulty occurs. And another important thing that we use to avoid the succinylcholine or the scoline, the paralyzing agent in most of our kids, because these increases IOP up to 8 mm of mercury, and which will last for about 10 minutes. And LEILA madam operates for 10 minutes only. So all this, her operating period, this IOP will be higher. So we avoid these drugs. And our volatile agents all lower IOPs, and nitrous oxide have minimal effects. Opioids, atropine, and ondansetron also have minimal effect. And on the contrary, are your medication making the anesthesia difficult? Yes, it is, because you prescribe beta blockers, prostaglandin analogs, and carbohydrate inhibitors. All these can cause various problems for us to deal with, like the beta blockers causing bradycardia, arrhythmia, and bronchospasm in asthmatic individuals, and prostaglandin analogs again can cause bronchospasm in susceptible asthmatic kids. And these carbonic anhydrase inhibitors like acetazolamide, topical or oral, can cause mild hyperchloremic metabolic acidosis. And most of these drugs causes renal electrolyte losses. So many of them present with hyponatremia and hypokalemia. And another thing is that our phenylephrine, the most common eye drops we put intraoperatively and perioperatively, can cause tachycardia and hypertension. We had many incidents of accelerated hypertension in susceptible individuals with the use of your T+. So that contains phenylephrine, and the literature says that when these T+ eye drops trickle down the nasal mucosa, that causes the major absorption. So it's prudent to occlude this nasolacrimal duct when you put T+ intraoperatively. And coming to the local anesthetic agents, all these local anesthetic agents, when used topically, also can cause local anesthetic systemic toxicity, what we call as LAST. And that is more true when we are using it for the premature neonates. Coming to individual surgeries, I will brush through these all individual surgeries and individual anesthesia problems like the EUA, the examination under anesthesia and the measurement of intraocular pressure. Most of the kids used to come to us with these kind of procedures. So we prefer inhalational induction rather than giving IV drugs. And we use a face mask to keep the baby under the anesthesia. And we tell the ophthalmologist to measure the IOP before the airway manipulation or before giving any other induction agent. So we induce the baby with the face mask. Then what we do is we tell the ophthalmologist to measure the IOP. Then we will keep the baby deep for the further procedures. And we keep our anesthesia technique consistent because these kids used to come again and again for measuring the IOP. So we keep our anesthesia technique consistent for the baby. We record our anesthesia technique and we keep it consistent for the baby. Now, glaucoma, most of the cases in larger children, we do it under MAC or IV sedation or GA with a spontaneous respiration. We avoid ketamine and scoline in these cases, and we institute a synchronous intermittent mandatory ventilation, pressure control ventilation modes, and CPAP, continuous positive airway pressure modes for better. Those are better than our unmonitored bag ventilation. Coming to the cataract surgery, the anesthesia should, most of the things I've already discussed, and anesthesia should provide motionless eye and aim for a smooth emergence. The era of crying and struggling babies post-emergence is long gone. So we keep our babies well sedated in the post-operative period, and we keep them under ICU or care for at least 1 or 2 hours. And the strabismus surgery has the highest incidence of exhibiting the OCR. What is OCR? The oculocardiac reflex and postoperative nausea vomiting. Strabismus surgery is mostly painful, and we judiciously use perioperative analgesia, including opioids. And we can give paracetamol NSAIDs for the postoperative analgesia. And ocular myopathies have been rarely associated with a malignant hypothermia. So we purposefully avoid succinylcholine and institute temperature monitoring in our kids. Coming to the oculocardiac reflux is profound bradycardia, which is very rarely can result in a sinus arrest. This is caused by the pressure on the globes and or the traction of extraocular muscles. That's more common in children because they have a higher vagal tone. Is mostly seen as a complication of strabismus surgery, enucleation, vitreoretinal surgery, and orbital surgery. Basically, extraocular muscle stimulation can cause OCRs, and the surgeon should be asked to release the traction on the eye muscles and pressure of the globe as a first instance, and if it is not responding to that, we give atropine or glycopyrrolate. Coming to the postoperative nausea and vomiting, we should understand that ophthalmic surgery itself is emetogenic, and we institute dual therapy in our kids with ondansetron and dexamethasone prophylaxis. And we use as a third agent for the rescue therapy, mostly domperidone or metoclopramide for the kids. And coming to, I will take a couple of more minutes. Blocked nasolacrimal, these kids coming for the short procedures, and in these cases we can use breathing spontaneous with a supraglottic airway devices, and suction catheter can be placed in the nose and pharynx to prevent aspiration. This surgery can be painful and opioid may be needed. Bleeding from the nasomucus can be ameliorated with the topical vasoconstrictors like a T+, and as well as the our oxymetazoline nasal drops. Throat packs are used to protect the airway from the aspiration. At the end of procedure, airway should be suctioned clearly and remove any clots and debris. Coming to the retinoblastoma, these children require multiple general anesthesia sections for EUAs, and these kids used to come to us for as frequent as 4 to 8 weeks. Another important aspect I wanted to tell is intraarterial chemotherapy. This intraarterial chemotherapy is known to produce hypokinesis of heart, something known as myocardial stunning, that can occur up to 40% of kids. And atypical bronchospasm can also occur, and review of the previous anesthetic records are mandatory because these kids might have gone to higher centers for the intraarterial chemotherapy and they might have recorded a myocardial stunning. So if it is prudent, we can wait up to 4 weeks for the myocardium to recover before accepting for general anesthesia for a second sitting. Also, the retinopathy of prematurity, the cryotherapy, laser photocoagulation, anti-VEGF monoclonal antibodies, all these treatment we may require general anesthesia. So most of the cases are done under mild sedation or topical agents. Many cases may need a postoperative support in the NICU if we are giving general anesthesia. And retinopathy of prematurity, again, the ROP kids come for when the general anesthesia or sedation is necessary. Our concerns include the respiratory and cardiovascular prematurity, hypothermia, and hypoglycemia. So we accept these kids with a consent to shift to NICU in the postoperative period. And we keep the operation theater temperature to 25 degrees Celsius and active warming, including the warm beds and warm blankets and hot air fans, etc. are used. Many of these infants will require postoperative ventilator support in NICU. Thank you very much for.
Thank you, Dr. Didip Chandra, for that exhaustive coverage of all the conditions which need anesthesia. Thank you. So actually we have a PowerPoint sent by Dr. Sumita Agarkar, who was supposed to be here with us, and her flight has been preponed a bit, so they are going together. So she has sent, if anyone would like to see the, she is supposed to talk on IOL power calculation in children, which again is a debate topic where under correction, which type of under correction has to be done, or which IOL formula to use. So if anybody is interested, I can put the, would like to see. So can you please?
Ma'am, can I ask a question
Yeah.
to the
Dr.
doctor
Sumita
who
Agarkar.
presented earlier? Dr.
Dr. Dwidib.
He's an anesthesiologist. Yeah. So actually, I have a child who's come for squint surgery, and with a sudden onset of squint. So when we evaluated him, everything was normal except he had a positive anti-acetylcholine receptor antibody. So that came out as positive, but his myasthenia workup was negative otherwise. No ocular or evidence of ocular or systemic myasthenia, no ocular motility limitation. So we repeated it again. Again it came out as positive. So now they have done all therapies and now they want us to do surgical correction. So what would be your take on this?
Basically, it's a very tricky situation because these kids can go for postoperative ventilation. So what we do is, these kind of kids, we avoid giving paralytic agents. What we do is, we will keep the baby under anesthesia, that means GA, with a spontaneous respiration, or with a little bit of support from the ventilator. So in the advanced ventilators, we have modes like SMV, that means synchronized intermittent mandatory ventilation, or CPAP also we can give. And in the most advanced system, what we are using in Contrast Eye Hospital, we have something called as PSV Pro. That means the patient's on ventilation, but the ventilator is giving some pressure support to the baby so that the tidal volume is maintained. So the respiratory effort arises from the baby itself. I wanted to make it as simple as possible so that ophthalmologists understand this. So basically, the baby is spontaneously breathing, but the ventilator is giving some pressure to the baby so that the tidal volume, the ETCO2, everything is maintained normally.
So
So
avoid all the
basically we
ETC
avoid
agents,
all the paralytic agent we are avoiding. But still, like in case of something goes wrong, we may have to have a backup plan. So we need to counsel the patient party for the postoperative ventilation, because in case something goes wrong, you are unable to intubate with the spontaneously breathing baby, we may have to paralyze the baby. We may use a short-acting agent, but still the baby can go ahead, go for a complete paralysis. In case this, I had an experience with one of the babies who was not detected these anomalies pre-operatively. So we have given paralytic agent, and this baby had to be ventilated for next 24 hours. So usually, even if with all these problems, the babies come out of ventilator in next 24 hours. So we can take up the case, but with a lot of counseling and a lot of cost counseling and explaining all this possibility to the patient party.
just one point I wanted to add. Thank you for that comment. That yes, anesthetic agents can also produce sometimes problems in this surgery, like fentanyl. And fentanyl can produce pupillary constriction, but then it goes away with intracameral adrenaline. Another thing is when you have a high ETCO2, it can produce a high positive pressure. So,
Exactly.
So that is another thing. If you're having a lot of positive pressure, I first look at the ETCO2 and I request my anesthetist if they can reduce the ETCO2 a bit.
Yeah, exactly.
Especially towards the end of the surgery, this happens when you're
And also
closing.
it increases the bleeding and your intraocular pressure, everything. So ETCO2 is a major culprit, like high ETCO2 is a major culprit in increasing IOP, increasing bleeding, and problems in the postoperative period. So I always put these babies into the ventilator whenever possible, because I don't want to do a back ventilation, so that one of the problem with the back ventilation is that the ETCO2 sampling won't be adequate. So most of the time what happens with the hand ventilation is that you will be inadequately ventilating the baby. But with an inadequate sampling of ETCO2, the ETCO2 may be shown as normal, but the actual ETCO2 will be higher. So I always put them on, our ventilator have all the facilities like supporting the spontaneous ventilation, paralyze the baby, everything we can do. So I put...
Which is your machine?
that is just a GE NXT, that is just for your information, it
very
costs
small-
just 8 lakh rupees, 8 to
No,
10 lakh
very
rupees.
small babies will still hand ventilate, that's why I'm asking.
Small babies to the what
That's
weight?
probably less than 10 kgs or...
No need. You can always ventilate the baby. In our setting,
I think we are operating even babies up to 1.5
1.5 kg, like that.
kg.
We are also operating, but my anesthesiologist
Yeah,
prefer
because-
to hand ventilate when the baby's weight is less.
Because
Saying
they feel more confident
Yes.
that this. But for your information, a couple of weeks ago we have ventilated 2.4 kg baby for a long retina surgery that lasted for more than 2 hours. So that is more beneficial to the baby, beneficial to the surgeon, beneficial to the anesthesiologist as well, because you are controlling everything and you have the adequate values shown in the monitor. When you are hand ventilating, all the things are is a guesswork. The pressure you are giving, the sampling rate, the temperature, everything is a guesswork. But oxygen level, everything is a guesswork. But when you are connecting that to a ventilator, all these are correctly monitored.
Thank you, Dr. Deep. That was very informative. Actually, I don't know how many of you have come across cholinergic syndrome, anticholinergic syndrome. Actually, it's very rare, but we are fortunate to have intracameral epinephrine nowadays, because we don't need to apply atropine or lot of these anticholinergics for a very frequently as we used to be. It used to be very commonly used because pupils are very small, we keep dilating. So I've had a baby who had, in fact we didn't use atropine topically, it was just hometropine. And then he went for severe, just like red as a hair, isn't it? I forget that in those hot as, yeah, everything, the tummy was like a balloon. And then we had to shift the child. Of course, in the very young who come with rubella syndrome, when we have 4 to 6 weeks surgery, during that time we already warned them that they may have to be shifted for a day to the ICU, because we don't have an ICU, neonatal ICU setup. But this child had to be taken immediately because the child was as red, hot, and due to paralytic ileus, the tummy was hard and bloated up. And then this was the diagnosis. Even with a hometropine topical, it can occur. But we have to just keep in mind that these things, because the antidote is very simple. It can be immediately tackled with if it is diagnosed on time. So that also we have to keep in mind when we use. But we are very fortunate to have this intracameral. But still we do have like rubella, pupils are very small and myotic. We do still have some problems, AC shallow. All these problems are there. But it is good. Let us go through this.
I would like to add one more point to that. You may not get all the features of this anticholinergic syndrome usually, but you definitely get paralytic ileus in the postoperative period. That is the most common complaint
Yes.
postoperative patients give us when we use atropine, even IV or topical. So these babies should be actually monitored for the abdominal girth and bowel sounds in the postoperative period. That we do. Thank you.
Thank you. So let us go through biometry and IOL power calculation. Please run through the. Can you run through it? As we know, IOL power calculation in children is different from that in adults, in that the axial length, corneal flattening, lenticular flattening, all these happen very fast during the initial 6 months, and during emmetropization, that is about 6 to 18 months, they have a fast corneal flattening from about 52 to 44, and then axial length from 17 to 24, and lenticular flattening also occurs. Yes, you can just run it. And next. So, that's what, I think you can just run, I don't have to talk. Please. So the pattern of axial length growth during the first 6 months, second phase up to 2 years, and beyond up to 3 years. That is why we usually in bilateral cataract, we wait up to about 18 months to 2 years to implant an IOL, and do it later as a secondary procedure. Next. So the myopic shift, axial length and keratometry measurement, IOL power calculation are challenges. Next. How we would measure? Of course, under anesthesia would be preferable, because children, immersion technique is good, or optical is not always possible in children, and coupling fluid is used in immersion technique. Yes. Next. So keratometry, now handheld keratometers are available. That is, under anesthesia you can calculate the keratometry and calculate IOL power. Next. Optical biometry in the older children, it is not it is possible, but in the newborn baby it is not possible. So these are the different. This is all the baby with the baby sitting, not lying down. Next. Next. So how optical is always better if it is possible in the older children, but immersion technique has to be done in the young. Yes. So so what is the target? Residual hyperopia from next. This is what we aim. 17 millimeter IOL power, what is this is approximate IOL power in a normal eye. So this is the protocol. When to implant an IOL, in the bag or in the sulcus. These are SRK, SRK2 are the commonly used as SRK2 and SRKT. Some comparison of accuracy of IOL power calculation. Lot of papers are there. They go for IOL power formula for SRKT has been found to be universally accepted for any microphthalmic and large eyes also. But Hoffman Q is better in small eyes, but we do SRK2. Yes. I think most of the Barrett's formula has been also studied well and used in the very small eyes when the axial length is small. I think that is when all these have to be taken into consideration. But during otherwise SRK2 or even Barrett's as an adult can be used. The predicted errors less below 2 years, SRK2 has been found to be the lowest. So that is why we take SRK2. Yes. Barrett's 98% error, predicted error within 0.75. In spite of all these IOL power calculations, a lot of predictive errors occur. We undercorrect for about 6 diopters and we see next day post-operatively it's just about 2 diopters or 3 diopters. It's not always as predicted that it comes. Actually, I think it takes still longer time for us to come to a predicted error 0. It is, I don't know whether it is possible at all. What is your experience? I would like to know from the panel, Dr. Satish. Do you exactly get what you predicted? I mean, 1 year old, you predicted 20% undercorrection. Do you get them?
Yeah, no, not always. No. But I don't fuss too much because anyway these are growing eyes. We don't know how they would grow. So there anyway there's unpredictability. So unless it's a gross error,
Yeah. I had a 4-month-old, not 4, 3-month-old, less than 3-month-old baby, and the eye was little small, but of course it is more 10.5, and axial length also was 17.5. And then considering the difficulties of contact lens wear and patching, I decided that I will implant an IOL. The power was 42, and then I implanted 30 diopters. You know, after 6 weeks, the immediate post-operatively, the post-op hypermetropia was 15. And then the child came for the first 1 month, 6 diopters. That is the growth. The child grows so fast that you cannot predict how hypermetropia would reduce. But luckily, he's having straight unilateral cataract, straight eyes, fixing very well. He's not using, now he is almost +1, +1.5 only. He's 1.5 to 2 years now, doing very well, no strabismus. It's very surprising, but I'm happy that I implanted the IOL because sometimes in the initial stages, I was really scared to see this +15. Yes. It varies from child to child. Usually by about 8 years, we can say if he is not myopic. If there was a myopia already, or if you see a posterior polar thinning, looks like a myopic child, that sometimes from the fundus examination you get an idea that it is going to be myopic. Then I've seen, like any other myopia, it can progress up to 18 years. Like myopia. So we have to follow them up for myopia. Very unpredictable, but in myopia more so. So that's why we undercorrect more in myopia. Especially in unilateral, you undercorrect more also. Then management also is difficult during the initial stages when there is a large anisometropia. So they have to be followed up because we can't discuss all these things. Unilateral myopia, unilateral cases, myopia, specifically you have to say undercorrection should be more because you expect the eye to go myopic again for a very long time.
Do you have any difference in the posterior capsulotomy in high myopes, madam?
High myopes, eyes are more collapsible because the scleral rigidity is less, and so sometimes, actually when you do PPC, you don't need to inflate more and make the bag very deep because catching hold of the posterior capsule becomes more difficult. And then in myopes, because of the collapse of the globe, it may keep on changing. The focusing may have to be
because
changed.
I burned my fingers once. It was like a high myope, and it was a Stickler's actually, and the vitreous was very thin. I did a proper capsulotomy and everything went on well in the bag IOL. And after 3 months, some severe trauma, the IOL dropped. So it was like a fluid vitreous. I could realize it. I should have put it in the sulcus actually. A 3-piece
Stickler is not very uncommon, and you don't.
Actually, the father also had that, but that didn't cross my mind. The brother also I did. Then I put it in the sulcus, 3-piece.
Usually Marfan syndrome, it is not the cataract which is troubling you. It is when the equator bisects the pupil. That is when they don't improve beyond 636 or something like that. Then till then, if we can be improved with either the myopic correction, if the lens has moved still further, and then FAK correction can be done, either myopic correction for the phakic part or hypermetropic correction for the aphakic part can be up to 6/18 vision you can wait. Usually they go on till 8 years. That is when we need to operate, but it is not a hard and fast rule, but that is the age between 8 to 10, later part of the first decade. I use mostly now for the past probably 2008 to 14 years I am using iris claw. Scleral used to be long time back, but not now.
Posterior
retrofixation.
I have given up iris claw lenses because I got a few atrophy of the iris. So I was feeling bad, like one side it got detached. Then I reattached, but still I feel bad. Now I do only SFIO.
Yeah, I think these patients have a predisposition for myopia also. Because the scleral rigidity is less. Marfan's, many of them have a myopia. They have flat cornea, they have high myopia. So the refractive status may not be big different, but because of the flat cornea also. But they have changes in the fundus like myopia. So you have to be very careful. I had a child who had a disenclavation of one iris claw, and then it was re-enclavated. He came after 6 months with a retinal detachment. He was high myopic, and so whether the surgical, because they have fluid vitreous also, so we have to follow them up closely, because immediate post-operatively, he had good vision, so we can't ask them to come after a very long time. They need to come again. Especially if they already had a re-enclavation and second surgery, better to follow them up very, very closely. Because that child came for RD, with RD after 3 months. So we don't know when it happened. So they need to be closely followed up. Retinal detachment, touchwood, is not so very common as a complication. It is there, but we don't often see, isn't it? Do you? RD.
RD is rare.
Isn't it?
Very rare.
Yeah.
Yes. Only, madam, what is your experience in small pupil using hooks?
Actually, the other, I am very fond of most of these ring closed loop dilating rings and loops, but not in children, because all these cases have microphthalmia, and shallow anterior chamber, as already pointed out, is the most difficult. Only iris hooks can be used, and then they keep on, because it may slip. And then it is very, very challenging in a child with a shallow anterior chamber, myotic pupil. Rubella used to be very common. I think for the past 3-4 years, we are seeing more of CMV as an infectious cause, isn't it?
Yeah. True.
Do you also feel so? Because after the immunization became mandatory.
Videos have showed all of them are CMV positive.
All of them are CMV positive. Now, initially, I used to always point out rubella as the cause, but rubella has come down now. And rubella used to create all these myotic pupil, small eye, calcific capsule, then anterior vitrectomy. Anterior capsulectomy has to be done with the vitrector. It's not possible to do a manual rexus. So all these problems put together in the rubella cataract, you have to follow them up for glaucoma. That is the most important. Second surgery is not very common. As she has already shown, inflammatory membrane occlusio pupillae can occur. Don't very commonly, because always we don't implant an IOL. And always in these children, very young children with small eyes, do a large capsulotomy so that the pupillary area is clear. And a good vitrectomy with so that not very common, but it can occur. Inflammation is very common.
I was thinking like whether you can give something to prevent this inflammation, because first post-op day it's okay, and first visit it is okay, but it's coming later.
I don't know. This is not a standard practice, but I give a very short of systemic steroids.
Systemic steroids have
immediate post-op. Yeah, aggressive. That's what I do up to 9 years in older children. After 1 or 2 days of injection on the table, I do give one shot.
Usually in anesthesia you give no injection, steroids are given, no?
No, do
We
you?
usually give one.
Do you?
Our anesthetist give.
Sorry, I didn't.
Do you
Steroid.
routinely give steroid for children during anesthesia?
No,
I don't
exactly,
think
madam.
so.
Like
Here,
we
we
selectively
give.
give for strabismus surgery because that is most emetogenic. So in those cases, we institute dual post-operative anesthesia preventing algorithm. Otherwise, not needed. But many patients may have some upper respiratory infection or hyperreactive.
No, I
in these
meant
cases, we may have
steroids.
to give.
Steroids.
Yeah, these
Dex-
patients. No, let me clear about it.
Routine steroids during anesthesia.
Routine steroids are not indicated during the anesthesia, but what I was telling is that postoperative nausea vomiting prevention, this dexamethasone has a role, like a dual therapy with the dexamethasone and emisset ondansetron has a role. So
This is for the edema or
what?
dexamethasone?
Dexamethasone is for reducing nausea and it acts at the
For the
CTZ.
tract or for the eye?
For the CTZ.
Huh?
For, we are giving it for the something called the chemotactic trigger zone, which stimulate this nausea. So when you are giving dexamethasone, that will prevent stimulation at the CTZ. Chemotactic
Central.
trigger zone,
Central.
central action. And for emetogenic surgeries like strabismus surgery, we routinely give dexamethasone. Or if the patient has a hyperreactive airway, like an asthmatic kid or a recent upper respiratory infection, these cases we give dexamethasone. Otherwise, no routine role for steroids in anesthesia.
I think in our place they are giving because we usually ask them when we plan to give, no, then they say that we have given already. So we start only next day.
Yeah, I always on the
That's a
table.
good plan. Like some cases, you have to communicate with the
Yeah,
anesthesiologist.
they usually say that they have
Mostly,
given.
most of the people this dexamethasone has multiple beneficial effect intraoperatively and postoperatively. So many anesthesiologists has a practice of giving it routinely. Is there any contraindication from the opthal side for this?
No
No,
contraindication.
actually it's good.
It is good. It is good because I do give on the table according to the
Used to tell me also give
Yes.
steroids on table.
Yes. Newborn babies 4-6 weeks I give half cc on table. Then next day and we don't remove the IV line till next day when we see whether there is inflammation. You can see a very clear AC with pupil, round pupil, mid-dilated pupil or briskly reacting. Then we switch to oral. Otherwise, if you still think there is something, then we give a second shot next day. Usually post-operative within
But it comes later also.
it can come. That is why frequent follow-up is important during the first 2 weeks.
Not the usual MLR, all those behave very well. But these microphthalmic eyes and with PHPV, it can come later.
Yes.
No, because some of the patients I know that they are looking after the baby really well because they are quite educated. Even I told them like that child was positive, I think cytomegalo. Then I told them like you look at, I just showed them how to look with the torchlight. And that next day they got that. When they saw that pupil was occluded, no, the parents were IT people. They brought the child immediately. IOP was normal in that child. Immediately as they saw the pupil was occluded, they brought the child. Actually, it was just first 2 days we give 1 hourly. After that 2 hourly and then 4 times we bring it down. But this child actually it was continuing as 2 hourly because I was expecting this. So they got the child immediately. I did a membranectomy, opened the pupil. I was quiet. IOP was not raised. But after that, child went home. Again, the same thing happened. Then Dr. Divya, a retina specialist, she did a pars plana membranectomy. Now the child is okay. So something is there, like
Yes,
which is inducing the inflammation.
lot of things which occasionally, very occasionally, they come out of the way. But otherwise, because of the because of probably good vitrectomy and PPC and all that, over the years I have found that they do very well. Than
Usually,
previously.
rarely you get such
Inflammation
cases.
is not so very common
Usual pediatric, no.
with steroids. Yeah.
The video I showed with occlusion was not the baby I'm talking about. That baby, they were from Malappuram. They came after 3 or 4 weeks, and it was really bad. And it was a bad microcornea also. And one eye I couldn't save actually. I did all the membranectomy, retina people saw. And the other eye now is just like a pinpoint pupil. I'm afraid to touch it because there was so much of fibrosis. Whatever I do, no, again the fibrosis comes. So I said, don't do anything in the other eye. I sent them for a second opinion everywhere because I didn't want to touch on that eye. Child is seeing well. Maybe somewhere through the small pinhole they're seeing. But you can't touch that eye. This eye we couldn't save whatever we did. Yeah, that can, but that I've never seen
child,
actually,
yeah.
don't know.
Because ophthalmos, according to our definition, is less than 20, and all these children, when we have to do, it is before definitely 16.5, 17, we don't know. But we have not specifically looked for non-ophthalmos, but definitely they are difficult cases to do. Real microphthalmic eyes. And micro, all of them mostly they have a small pupil also.
Yes.
And post-operative management is more difficult because to see the fundus, cupping, all these are very difficult. You put any number of atropine or whatever, and so then you have to put under, even under GA, seeing the disc is very difficult.
The
sometimes.
corneal, if you have a decent corneal diameter, then your surgeries will be okay. Corneal diameter small is the biggest. You can get away with the surgery, but this post-op problem is the biggest hassle. Hmm?
Means glasses instead of contact lens if the parents are not at all. That is the most often that is the case because we routinely give contact lens. The second time they come, they ask for a spectacle only, but it is still difficult because the other eye is seeing. So then making them wear contact spectacle and patching is very difficult. That's why even below 6 months, we prefer to put an IOL.
Yeah. Otherwise, there's no point. And unilateral cataracts, now I put IOL very early. If
I
the
put
corneal diameter is more than 10.5,
Sometimes it is
almost 10.5, and the capsule is more or less rigid, little bit rigid, then I put the IOL and I'm putting 3-piece in the sulcus. So I'm thinking anything happens, remove it and replace it.
we do also the same, and we push it to 10.5 to make it 10 to 10.5. So it's very subjective because that gives better
Results are really good.
post-operative. Let's see, many children with an IOL management post-operative is better, definitely better than no IOL and spectacle. Vision also, long-term vision.
What a time, 1:30.
Thank you so much.
Okay, thank you. It was a nice discussion.